Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anyone.
Now, very important question. This little man is asking you, should we give steroids after 35 weeks? That's what my next slide is about. So they said the recommendation was between 24 weeks to 35 weeks, 34 plus 6. So should we give steroids after 35 weeks? If yes, why? If no, why? Can anyone quickly tell me? I don't know this answer has come recently for this question or some other question. I don't want a yes or no. I want why. Why do you want to give after 35, if at all? Or why do you don't want to give after 35? Will the benefits be more? Will the risks be more? What do you think? What do you think? That's the question. So 43 students are there, but I don't know where these people are in answering the same question. The same students are replying me, and I don't know where the other students are. Risks a little more? Must be. Okay, without seeing the the statistical figures, this is what comes into our mind. Why have they been only recommended to 34 plus 6 weeks? Because maybe the benefits are questionable and the risks are definitely there. Because see, giving a steroid, number one, it's an iatrogenically induced hypoglycemia for the neonate and hyperglycemia, or at least a deranged glucose tolerance for the mother. Correct? That's a very important, robust first point. We're iatrogenically inducing a hypoglycemic state for the neonate and a hyperglycemic, or at least an impaired glucose tolerance situation for the mother. Right? Number one. Number two, with questionable benefits, but with certain problems like delayed developmental delay or something like that. Developmental delay, delayed childhood development, right? So maybe that is one very important part, that we do not know a lot of benefits, because 34 weeks and onwards, baby usually does not have a lot of respiratory distress trauma, usually does not have a lot of TTN, does not have a lot of IVH. So what are we actually gaining out of giving steroids? But at the same time, it's giving a lot of problems, both to the mother and the baby. Yeah, let's now, with that mind, let's go ahead. So there is one definite advantage between 35 to 37 weeks, that it's likely to reduce the respiratory support. Baby will be able to breathe on its own. It might not need an external source of, let's say, intubation or CPAP, BiPAP, or ventilator or something like that. And it is likely to increase, but that was the benefit of this, likely to reduce the respiratory support, but it is also likely to increase the neonatal hypoglycemia, which I said before also. May increase psychiatric behavioral diagnosis if the children are born at term. May increase. See, this thing is, of questionable concept, but still I would like to include it because it was there in the guideline. While no long-term harms have been proven, large-scale observational studies are necessary for pharmacovigilance. They are lacking. So benefits seem unlikely if birth is more than 7 days has been delayed, that we all know, but this is the advantage and this is the absolute disadvantage. All right. So the next question. If you plan a cesarean section at term 37 to 39 weeks, what advantage and what disadvantage do they get? Let's hear. May decrease the admission to NNU with respiratory morbidity. So basically, you are seeing one thing I'm repeating again and again. Best thing about steroids are that they reduce the respiratory morbidity in every strata of patients. We were having a doubt between 35 to 37 weeks. There's the answer, reduces respiratory support. Then we were thinking about why we're giving in cesarean section between 37 and 39 weeks. So it's again reducing the NNU admissions because of respiratory morbidity. But there are questionable things coming here. See, may reduce educational attainment at school. I did not see that in my children though. All right. But yeah, may reduce educational attainment at school age. Increase in the proportion of children ranked by teachers as being of low quartile academic ability from 9 to 18%, and reduction in proportion of children obtaining English proficiency from 13 to 10. This is very, surprising to hear these things in a GTG guideline. But yes, so that's what they've surveyed, they've found out. These are all robust evidences according to them that might reduce educational attainment at school age is what they have found out. So there is an uncertainty whether there is a reduction in RDS, TTN, or any new admissions overall. The risk of bias in the single central study remains, means that there is low certainty around the estimates. Short-term complications, definitely hypoglycemia, and that has not been rigorously studied. So they're giving themselves the lacunae in their research, and they're telling you to, base your decisions accordingly. That's the idea of these recommendations. The certain things are black and white, but there are certain things which have been seen, but not very robust evidence is there with them. So they are telling you very honestly. That's the idea, right? So there is no, so if somebody asks you that should it be given, should a routine steroid course be given before a elective cesarean section, your answer should be no. There is no absolute recommendation of such a thing. Benefits versus risks should be weighed, and an informed decision should be informed consent should be taken from the patient, telling her regarding the benefits versus risk ratio. If they ask you to tell me what are the benefits, you would say that it has seemed to be reducing the new admissions because of respiratory support. And if they ask you what are the risks, the risk of attaining lower in educational institutes at childhood age have been seen. All right. Now comes the question which my students have been very aggressively asking me. What about the rescue dose, whether it should be given now? Here, let me just clear certain things with you. You were asking me what is the meaning of a routine dose, a rescue dose, and repeat dose. Very important, very conceptual question. Let me tell you that now. There is nothing called a routine dose. There is nothing called a routine dose. Okay. What do you mean by a routine dose? Let me just give you an example. For example, I have a patient. She is 32 weeks and she is, let's say, a triplet pregnancy. So now she's come to 32 weeks. I'm giving her a steroid course. Why? This will be called as a routine course. There is nothing called as routine course in when you're talking about steroids in pregnancy. It does not mean that a triplet pregnancy has reached 32 weeks. I just give her steroid. But yes, if she is showing any signs and symptoms, or I'm planning a C-section because of whatever reasons on her, in a week or so, I would give a steroid shot. That's two different things. Okay, so there is nothing called a routine steroid shot. Let's say, okay, she's reached 28 weeks, she's a twin pregnancy, I'll give her a steroid shot. No, until unless there is some activity. Okay, her cervix is shortening, or she is having slight contractions. She's been admitted with, pain, abdomen, and some cervical or uterine activity is there. I'll not give her any steroid shot. Okay, that was routine. But there is nothing called routine. There's always a a rescue dose only. Then repeat doses. Repeat doses also. I'll give you an example. For example, I have a patient of placenta previa. I've given this example multiple times in multiple of my classes, and all my old students know this. So if I have a patient, in fact, I did have a patient of placenta previa, and she came to me at 28 weeks of gestation. I admitted her. She came with a complaint of bleeding PV, and mind you, placenta previa keeps coming with this. What do I say? Placenta previa, this thing, bleeding PV. Yeah. So she came to me at 28 weeks. I admitted her. Her bleeding subsided in 2 days. She comes to me again, let's say at, wait. She comes to me at 28 weeks. We admitted her. Her bleeding subsided in 2 days, when it again started on, let's say, the 5th day. And she was admitted, or 4th day when she was admitted, or she was about to go home, it started again. Now, since she's on the cover of steroid for 7 days, I did not give her a repeat dose, all right? But when she was admitted, she was slowly spotting all the time, all right? Now she's been spotting. And again, when I discharge her, let's say now on the 10th day, she spots again. So I give her another course, a repeat course of, steroid. And all the time, then I say, going back home and coming back, it'll be very difficult for you. And who will be there to monitor? Suppose you suddenly start bleeding, then at least you should be in the hospital setup. So she starts living with you in the hospital. That also happens in many institutes. And she's living with you in the hospital. And now it's been, what you're doing is that every week in an anticipation of sudden emergency cesarean section, you're giving her repeat doses of steroids. No, a big no. That is called repeat dose. Routine dose I told you, repeat dose I told you. Suppose a patient of placenta previa, she's been bleeding on and off, so you don't let her go home, you just keep her with you in the hospital, and every week you're giving her a course of steroids. That's called a repeat dose. You will not do that. That is not recommended. Okay. Now let's talk about rescue dose. Rescue dose, now in this patient only I'll tell you. This patient came to me at 28 weeks with a bout of bleeding PV. I admitted her and I gave her a steroid shot and in anticipation of a probable delivery, because if her bleeding doesn't subside down, but it did subside down on the, let's say, the second or the third day. And she is now being discharged, let's say, on the 5th day. And then she comes to me at 32 weeks with another bout of bleeding. She came to me at 28 weeks. I stabilized her, and now she's come to me at 32 weeks with another bout of bleeding. Now the baby is more mature than 28 weeks to be delivered out, just in case it's needed. And now I'm thinking, what should I do? I've already given her one course. Should I give another one? So if at this point in time, it looks that the delivery is imminent, okay, or the chances of delivery are there. For example, her bleeding from what it was at home has now increased, or earlier there were no contractions, now there are. In that case, you are anticipating a delivery. Maybe yes, one rescue dose can be given. Okay, so that's called a rescue dose. And most of the time that you're giving steroids, guys, you are giving rescue doses. Okay, you're not giving any routine dose. You're giving because you have to give. It looks like that she's about to deliver, or you might have to take out the baby. You give at that time. That all of them are rescue doses. And the same dose, if you give it repeatedly for one more time, that will also be called as a rescue dose. That will not be called a repeat dose. Okay, I hope the concept is clear now. I hope the concept is clear. I'm still seeing in the chat. I want my students to understand. Yeah, I'll get to that bit. I'll get to that, betamethasone or dexamethasone. Which one to be given, that I'll tell you by the end of this discussion. But both are very potent, okay? But thus the dose should be given properly. It's not important which one are you giving. So I'll tell you the exact dose once we get to the end of the class. Both are given actually 24 only. Both are 24. And yeah, no half dose, complete course. Whenever you're repeating, I think that was your question. Whenever you're repeating, you have to repeat the entire course, not just one shot. No, that's not the recommendation.